Thank you. I feel a bit embarrassed, really. I am just a woman who's trying to help other women, actually. There isn't really much special about me, but I am on a bit of a mission. So it's a real honour to be here, actually, for two reasons. Firstly, because of all the amazing work that Leigh do, but also to be here in real life. It feels a bit weird that I'm just not looking above my screen, making sure that I have eye contact with absolutely no one. So to have a real audience is actually very exciting. Firstly, just to declare my interest, actually, I don't have any conflicts, really. As has been explained, I'm a director. Actually, it's the largest menopause clinic in the world. We've decided we can't find one bigger. We see over 2,500 women a month in my clinic. I have 71 clinicians who work with me. It is a private clinic because none of us can get jobs in the NHS, not because we're bad, it's just because the jobs aren't there and the resources aren't there. I've set up a not-for-profit company. We've developed an education program, which has been now, we've made free, actually. The company is so in debt, I might as well keep it in debt. So we've decided to make it free. So we've had over 16,500 healthcare professionals in the last few months that have downloaded our Confidence in Menopause course, and we're just launching a Menopause Society, actually. The free app has been downloaded and actively used by over 300,000 women, despite us not paying a penny on advertising, by women from over 150 countries. So this is part of my mission to improve the global health of women. And I'm the founder of the Menopause Charity. But I do have a small conflict, and that's actually that I take HRT myself. If I didn't, I would have given up my job, and I certainly wouldn't be standing here today. So I just wanted to start with the patient. It's really important, isn't it, to be focusing about what we're doing, why we're doing. And, you know, the reason I work so hard is women, actually, the stories that I hear every day in my clinic. I'm obviously going to set the scene, talk a little bit about the menopause, female gender and immunity, about COVID, about long COVID, about potential treatments specifically for women. I did put research, but then I had to put lack of, really, because we're talking about women here today. So this is a lady I saw in my clinic. I have changed her name. You can't see what she looks like, but this is what a lot of women actually come and see me like. They're absolutely distraught. They've been really trying to get help. And we did a deprivation score, actually, of looking at all our patients that come. And they're from all socioeconomic backgrounds. They're from all deprivation scores, which is really sad, actually, because if you look on my website, it's eye-wateringly expensive to come and see me. They're paying because they feel like Julie and they've got nowhere to turn to. So she was a 49-year-old gym manager. She's been experiencing some flushes and sweats, changing her clothes several times a day, goes to work with a bag of clothes. Memory problems. It's quite funny when you find your car keys in the fridge, but actually she's forgetting her passwords at work. It's quite embarrassing. Her sleep's very bad. She's having early morning wakening, so she's not just waking because of her night sweats, but she's also having very intrusive thoughts. She's also very anxious. She's no longer driving, becoming very socially withdrawn and isolated, and she has health anxiety anyway, which has really worsened recently. So just finding out a bit more about her, she was also experiencing muscle and joint pains, which was affecting her ability to exercise. She explained she was often worse in the morning and her stamina had been reduced. She noticed even when she worked out, just building up muscles was very difficult. And she described, like so many of my patients, that just walking down the stairs, she felt like an old woman. She was also experiencing some pins and needles down her arms and legs. And we ask our patients, actually, the ones where it's relevant, about libido. We're very British, we don't like to talk about sex often, but it's very important. And again, sadly, like many of my patients, she stopped having penetrative sex because it was so painful the last time she had it. She still adored her partner, but she wasn't interested in sex because of the discomfort. And she said, actually, now I just feel numb from the waist downwards, but even sitting down can be quite uncomfortable. Walking, actually, is painful as well sometimes. She was having some stress and urgency, incontinence, and recurrent urinary tract infections, which were really troubling her as well. So she'd had a diagnosis of various things in her notes. 2016, she'd been diagnosed with fibromyalgia. 2017, a frozen shoulder. 2018, she'd actually been diagnosed with MS. 2019, she'd been diagnosed with raised blood pressure, and she was worried because she had a family history of cardiovascular disease. 2020, she'd had a DEXA scan, a bone density scan, showing that her bones were thinner. She had osteopenia, and she was worried because she had a family history of osteoporosis. And then this year, she'd been diagnosed with long COVID. She thinks she had COVID last year, like many of us wasn't tested at the time, and she'd been referred to the local long COVID clinic. She'd had numerous investigations, she'd been referred for psychological treatments, and been advised to do graded exercise, which I've already explained was really difficult for her. And she'd also been diagnosed with chronic fatigue syndrome. She thought some of this might be due to her hormones because her period stopped in 2015. And much to everyone's surprise, women aren't stupid. We often know when things are related to our hormones. So she thought maybe this was related, and she'd asked quite a few healthcare professionals and even asked for HRT several times, and she'd been told it was too dangerous for her to take. So we'll come back to her at the end. So the menopause obviously affects all women. It can be a natural process for many of us because our eggs run out of producing, our eggs run out, the hormones associated with our eggs decline. The average age, not that any woman is average, but the average age in the UK is 51. But many of us become perimenopausal before, where our hormones start to decline and we start to experience menopausal symptoms. So our periods can even be regular, but they're often a bit all over the place. And these symptoms can last sometimes for a decade before the periods stop. But 1 in 100 women under the age of 40 have an early menopause. We call it premature ovarian insufficiency. So as you can imagine, there are a lot of women in their 20s, their 30s and 40s who are perimenopausal. And then most women in their 50s will be menopausal. Our life expectancy as women has increased, which is great. So in the UK, it's 82. So that means about a third of our lives are postmenopausal. And this is meaning that we have low estrogen and testosterone levels in our bodies, and they will stay low regardless of whether we have symptoms or not. And there are health risks associated with the menopause as well. So we actually really need to think about the menopause not just as something that causes a few hot flushes and sweats, but it should be thought of as a female hormone deficiency with actually not insignificant health risks. And if you think about estrogen, the sort of bread and butter hormone for women, if you like, we have cells that respond to estrogen all over our bodies. Every single cell has an estrogen receptor in it. And this is why it's so important when we think about symptoms, but when we also think about the way our bodies function without it. So why do we need to worry about it? Obviously, it's been so much in the press over the last few years, which is good, but it's more than just a word. Women are suffering, and actually they're suffering more than people realise because a lot of women themselves don't realise their symptoms are related to their low hormones. We need to think about the health risks. We need to think about the health risks because they're worse the longer people live, and I've already said we're living longer. So the risk of heart disease, of osteoporosis, of diabetes, dementia, early death, and actually suicide as well. I'm investigating another case this week, actually, of a 51-year-old lawyer of 3 children who took her own life. Her symptoms started when she was 49, when her periods changed. She thought it was her hormones. She told psychiatrists, she told psychologists, even when she was sectioned for 3 months. But earlier this year, she jumped off a bridge and killed herself. And I hear stories like this a lot. Every day in our clinic, we see extra women who are suicidal. And we know it's related to low hormones because they get better when their hormones are replaced. So living with hormones, despite what some people try and tell us, is not natural, actually. We're not designed to function without hormones. And we've already heard about midwives, but it's really staggering if you think about the NHS. 77% are women. Around half of those women are menopausal. We know it, around 20% of women actually give up their jobs because of symptoms such as fatigue, memory loss, and anxiety. So we're losing a lot of workforce from the NHS. Sorry, it's just gone blank here. I don't know, my screen's just gone blank here, so I can't see my slides. So why are we worrying? I've already said 50% of our workforce are menopausal women, and this has a real impact on the future of the NHS. But not just in the NHS, 13 million women who are working are either perimenopausal or menopausal. And around 20% of the population, so 1 in 5, are menopausal women. So what are the health risks? I've already alluded to them actually already. So these are the most important ones. And if you think, most women actually die from cardiovascular disease or dementia. And we know that women who go through the menopause are 5 times more likely to develop a heart attack. And actually when women have a heart attack, they're twice as more likely to die than men, yet it's not being picked up. Also, COVID severity, which I'm going to talk about in a minute. But we also know, thank you, that women have an earlier death from any cause when they're menopausal. So it's quite doom and gloom for us menopausal women. So I'm here to talk about the pandemic. So we're always thinking about our immune systems, because actually if we've got good immune systems, we can fight infections, not just COVID. So partly we've got 2 X chromosomes, so we're luckier than men who only have 1 X chromosome, and most of our immune regulatory genes are encoded by our X chromosomes. And so a lot of people think it's purely because of that, which is important, but actually it doesn't always explain the difference between women at different ages. And so obviously all I do is think about the menopause, all I do is think about hormones, but actually I've also got an immunology degree, which is quite helpful when I think about the immune system and the way our sex hormones work. We know, obviously, that women who are young have higher levels of estrogen than women that are older. And I've already explained after the menopause, estrogen levels are low forever. So there must be something in it. When you think about the effect of estrogen on immune cells, this is a very busy slide, and I'm not going to expect you to know what all of these mean, but we've all heard about cytokines. We've all heard about these chemicals that our immune cells produce to try and protect infection. And some of them, they kill infections, but if they get too busy, they produce too many of these chemicals and they damage our own tissues. And this is what's happening in COVID, as I'm sure you're aware. People get this cytokine storm where a lot of chemicals kill the lung tissue and various other tissues, certainly in the kidneys and so forth. So estrogen actually stimulates a lot of these cells and helps the way that they work. We know that women have both a better innate and adaptive immune response. So that means we respond better to the initial infection, and then we have better immunity. So if it comes back, we're more likely to fight it. And so I feel a bit embarrassed really saying that whole man flu is probably a real thing. So the times my husband's had the same cold as me and he's been in bed feeling really ill and I've just thought he was a bit of a wuss, actually it's real, it's physiological. He doesn't have as much estrogen as me, so he is going to feel iller. So we need to give them more sympathy when it happens again. But we've known for many years that even sepsis in men is a lot higher than females. So I've already said these estrogen is so important for our immune function. So it affects the way our cells, our immune function cells differentiate. It can genetically reprogram them, can increase the number of them, the way they work, their efficiency. And it also regulates all those chemicals. I mean, the immune system is so mind-blowing. I did my degree in '92, so a long time ago, and things have really moved on. But the basics are still there, and it's just the whole balance of it working well, but not too well that it affects us. And we know that estrogen can attenuate this cytokine storm, which is really important when we think of COVID. So when COVID first came a thing and they started that awful thing in the papers showing pictures of people that had died, I started looking in the paper and saying to my husband, well, I bet she's menopausal. I bet she's menopausal. And he said, Louise, all you do is think about the immune system and about hormones. Can you just not think of something else? This is a pandemic. You can't get the menopause into a pandemic. I said, well, let's just see. But all we're hearing is noise about men dying and older women dying. So then this is just a slide that I found actually, and it's very hard to find slides about sex differences with COVID, even though COVID's been going on for a while. And if we look at the cases by age and sex, obviously we all know teenagers, children, young women have been having COVID for a while, but they're not dying from it. If you look at deaths, they only start coming in women really when they're in their late 50s and 60s. Maybe it's a coincidence, they're just a bit older, but maybe also there's something to do with them not having estrogen in their bodies, because we know men are dying at all ages. So we look at the death rates again, it's still, if you look at the way that the men, it's just gradually going up, but in women, 45, 50, 55, and then it starts going up more. Again, it might be a coincidence, but there's something there, you can't ignore the data. Then if you look in a really geeky way, which I am a bit geeky sometimes, if you look at the way the coronavirus actually attaches onto our cells and gets in our cells, if it's around, it doesn't matter if it's not doing anything. Once it gets in our cells, that's when damage starts, that's when people become really ill. None of us mind having COVID, like we don't mind having a cold or flu. It can be a bit annoying being in bed for a couple of days, but it doesn't need to close the whole world or the country. So it has these ACE2 receptors, this angiotensin converting enzyme receptor that it has to stick onto if if you like. And there's this protein called TMPRSS2 that is like a gateway. It lets the virus get into the cell. So they have to work really well. This is just another picture showing how once it gets onto the cell membrane, which is this turquoise thing then it goes in and then it duplicates, and then it's sort of game over, or it's really, people become very unwell then. But actually what's very interesting is that estrogen modulates the way the ACE2 receptor and the TMPRSS2 work. There's some good data even looking in vitro as well, but it hasn't really been picked up on. So why are women less protected then? So we know that it's an age thing. There's absolutely happens that when people are older, their immune system is not as good. But actually, we know that low estradiol levels are associated with more severe infection. And quite early on, when I was annoying my husband talking so much about menopause, there was a study from Wuhan that showed that women with low estrogen levels were more likely to have more severe disease in their lungs. And then actually, there was some mice studies looking at mice who'd had their ovaries removed, and they were more likely to succumb to COVID, more likely to have severe disease in their lungs than mice that hadn't had their ovaries taken out. We know that menopausal women no longer make large numbers of antibodies and cytokines, and I've already said the risk of severe COVID coincides with the start of the menopause. We also know that menopausal women have longer hospital stays for COVID than premenopausal women. So does it help? I wish I could answer, but it's really difficult to get an answer. But if we look, we've already known that there are less deaths generally in women who are young, who are pregnant when they've got very high levels of estrogen in their body, and also women who are taking HRT, which contains estrogen. And there was a really good study looking at 17 countries showing that the fatality for women over the age of 50 was reduced by more than 50% compared to women not taking HRT. You know, this is headline figures. It's really important because this is better than a lot of the immunosuppressant agents that have been funded to really look at the trials, the evidence that's been there, the studies that have been done have been eye-wateringly expensive, but they've also haven't shown anything as good at that. And also, there was another study that showed from Oxford that women who were taking HRT were significantly lower. They had their odds ratio was 0.22, so about 80% less likely to die from COVID if they were taking HRT compared to women that weren't taking HRT. There's also the ISRAC data, which is the International Severe Acute Respiratory and Emerging Infection Consortium data. So this basically collects data from people that are in hospital, have gone to intensive care. And quite early on, I got in touch with these people and said, look, this is really interesting. Is there any way you can see how many people have been in intensive care who take HRT? And they said, well, no, we can't really get that information. And actually, why are you interested about HRT? Because it just gives people breast cancer, doesn't it? And actually, estrogen on its own is associated with a lower risk of breast cancer. So it's just very frustrating. So they have got all their hospital admission data, and they actually found quite early on that there was a statistically significant lower risk of death in women taking HRT. And I spoke to a few of the people on SAGE and said, look, this is really important. Can you do more? And they said, well, we're really busy looking at everything else. We're not really very interested in estrogen. So then I got hold of some researchers who were analysing the samples for all sorts of cytokines, different hormones. And I said, oh, have you done anything on sex hormones at all? Because I think it'd be really interesting. And they said, well, yeah, we have actually. I'll come back to that point in a minute. But they said, yeah, we've actually found that every person who's been in intensive care had low estradiol levels. But we don't know what that means. And I said, well, I think that's quite important because menopausal women have low estradiol levels. They said, oh, but we couldn't think of a disease that has low estrogen. So I said, well, this is quite important. Are you going to write it up or analyse it further? They said, no, not really, because we think there might be a problem with the machine, but we have checked it and rechecked it. But I think it's... or we're not going to do anything further because we're looking at other hormones and other cytokines. And I kid you not, when I say I've spoken to different people, we've actually been associated with 28 different research groups, and none of them are looking at hormones. And actually, 80% of the people we speak to are men, but they have got partners or mothers or sisters, so they should be interested. And I'm very happy for someone to disprove me or to disprove my theories, but at the moment no one can, but no one's thinking about estrogen. And I think maybe because it's for women, but actually men can have estrogen too to work as an immune regulator. And if I had a choice of estrogen or one of these immune suppressants that's going to really floor my immune system, I know what I would choose. So it's very hard finding research in women. This isn't about COVID, this is about women. We all know that. There's so many books about it. You don't need to go very far. And quite early on, when I was trying to do some research actually with some people in Liverpool and trying to engage SAGE about it, we were looking at how many research studies have been done in men compared to women and what had been written up, and there was 7 times difference, so 7 times more in men than women. And some of the researchers who are men who I spoke to said, gosh, that really surprises me. I didn't realise. I said, yeah, it surprises me too. I thought it would be more like 70 rather than 7. And I think people just aren't looking, and it's really hard to tease out data. So I found a paper that came out at the end of last year where they couldn't actually find any clinical trials on any pharmacological treatment for COVID-19, which included sex-stratified randomization in its design, which I think is really important because biologically we are different to men. There was only one study that actually decided afterwards when they were analysing to look at sex differences. And they weren't looking, and none of these studies, at sex as a potential effect modifier, which is really important because I've already said how different we work. We also know that estrogen works as an antiviral for HIV, for hepatitis C, for Ebola, lots of other really important infections too. And unsurprisingly, it's a lot easier, isn't it, to get men to do studies than women because you have to worry about women being pregnant and contraception, and that's really hard to ask and get women to be recruited to study. So obviously, more studies were done in men than women. So there's less research money, less attention on us as women. But actually, I think we do have a bit of a key that we could help. And, there's no reason why men can't have estrogen. They used to give estrogen to male inmates, actually, to suppress their mood. So there are ways that they have it. And actually, men do have estrogen in their bodies, the same as we have testosterone in our bodies. So moving on to long COVID. So long COVID is obviously very different to the COVID severity and mortality that I've spoken about. We've known from quite early on that actually, isn't it different? There's something different, isn't there, about long COVID to COVID, because you'll see the black at the top are women. So this is very different to the slides I've shown you already, where women were more likely to be protected. Actually, COVID, there's lots of women talking about that they've been diagnosed with long COVID compared to men. So 50% more likely to report long COVID if they're women. And someone I spoke to, another man actually, trying to do some research with long COVID, and he said, yeah, now in my clinic, I actually really feel quite surprised if I see a man. I think I have a different diagnosis, and often I can find another diagnosis for men. So it's really unusual, actually. They're all women that I'm seeing now. And women are more likely to have persistent symptoms. And again, if you think about the NHS, these are fairly recent figures, but I'm sure they're higher. 122,000 women who are working in the NHS have long COVID. Teachers, I worry, I've got 3 children. So that's a lot of women who are working or not working, probably, with long COVID. And this is a horrendous quote, actually. But you could take out that word and put lots of things, couldn't you? Actually, it's just hysterical middle-aged women. They're just whinging. They need to get on with it. And I can never imagine a quote like that if you remove the WO and just said men. It just wouldn't happen, would it? It wouldn't be allowed to be published. So what about long COVID and female hormones? Well, again, all I do is think about the menopause, actually. I just think about it all the time and dream about it sometimes because I get so cross, as you can hear. So actually, there's a lot of women in their early 50s with long COVID. So again, my husband's going, Louise, please think about something else, but I can't. I've already said the average age of the menopause is 51, but actually, rather than listening to me, why don't we listen to the women and see what they're saying? We also, whenever I don't understand what's going on, if someone's with me and I don't know what disease is going on, or I know the disease and I don't understand, I always go back to the basics, and that's probably because of having this immunology and pathology degree as well as a medical degree. So actually we know infections affect our ovaries. The last thing any of us want to do when we've got a big infection is to become pregnant. So our ovaries don't work as well when we've had an infection. We know that. And so a big infection like COVID, our ovaries are going to switch off. But also what's very interesting is we have lots of these ACE2 receptors on our ovaries. And I've already said the coronavirus attacks ACE2 receptors. So maybe our ovaries are having a worse effect because of the coronavirus rather than if it was another type of virus that we were having. And also, maybe actually women aren't being listened to properly. Maybe they haven't all got long COVID. Maybe they've got something else. So let's think about the symptoms of long COVID. These are only a few because the symptoms are added to all the time. But these are some of the ones, these are the more common ones that people are talking about. And then let's think about the symptoms of the perimenopause. And let's think about the symptoms of the menopause. Actually, they're all the same. So what differentiates them? Is there a test for long COVID? No, we haven't found one. Is there a test for the perimenopause and menopause? No, hormone blood tests are a waste of time. So what, again, do we do when we ask our patients? We try and get a diagnosis. I was always taught at medical school, the clue is in the history. You talk to the patients, Louise, the more you talk to them, the more you'll find out a diagnosis. So we decided to do a questionnaire through my not-for-profit, and we just flicked it out one evening and got 460 responses, asking women, actually, because I think it's always important to find them. So we asked women with long COVID. And we found that 51%, so just over half, had reported that their periods had stopped or changed, actually, since their COVID infection. Not all of them had been tested positive for COVID in the past. Some of them had, some of them hadn't. And the majority, 80%, said that their periods actually hadn't really returned to how they were before. So actually, if we take out COVID, that's all the patients I see in my clinic, really. That's where they come, because their periods have changed. So then we asked them, well, has anyone asked you about your periods in any of your long COVID clinics? Because there's more long COVID clinics now, and you've seen quite a few healthcare professionals. Well, around 1 in 10, just over, had been asked. So the vast majority, no one had asked them about their periods. And 16%, so not much more, had been told or given some information about the perimenopause or menopause, but most people hadn't, and that's partly because most people are a bit scared of the menopause because they don't know what it is or they don't know how to prescribe HRT. So again, women weren't really being listened to. 62%, so quite a lot actually, said their symptoms when they were having periods were a lot worse before their periods. And physiologically, what happens is our estrogen levels decline just before our periods. So that's why a lot of women get PMS, because their estrogen levels decline. So actually, these women are telling us, when my estrogen levels are lower, my symptoms are worse, is what they're really trying to tell us. But again, they weren't really listened to. And actually, most of them, again, because women aren't as stupid maybe as some people think, is that most of them thought that their symptoms of long COVID could be a result of their perimenopause or menopause. So are these women having a perimenopause or menopause induced early, or are they just women who otherwise would be diagnosed with fibromyalgia or chronic fatigue or recurrent urinary tract infections or depression or anxiety? So is it a different diagnosis because we don't know what to diagnose these women with? So this is another really frustrating time. I spend a lot of time banging my head against the wall. As Suzanne knows, I spend a lot of time very frustrated. I do enjoy my job, actually, but I do find it very frustrating. So over £20 million is spent on long COVID research. And actually, one of the ways that I'm working as an NHS advisor for NHS England is because when all this data was going on in my head, I had the privilege of actually doing a presentation for Chris Whitty and the senior clinicians team, which is probably the scariest thing I've ever done. So I presented everything, and I introduced myself saying that I run a very busy clinic and women are coming because they can't get HRT. And so some of the big opinion leaders were there and said, well, this is awful, actually. If women aren't getting HRT, we need to do more. So that's why it's happened. And Chris Whitty actually said, this is really interesting, Louise, and I think we really need to do more research in this area. This was about 8 months ago, and nothing's happened because no one's listening. And so now we've got £20 million spent on long COVID research, and I know where that money's gone, and I know what's been happening with it, and none of it's been done looking at female hormones. I was hoping to piggyback on a study just down the road from here where they were looking at giving 3 different treatments and trying to see if brain fog improved with long COVID, and they're giving antihistamines, which might help. They're giving a NOAC, which is like a blood thinning treatment, which I'm not sure I would want to take if I didn't really need it. and they're giving something called colchicine, which is like an anti-inflammatory. And I said, oh, maybe you could give some HRT, that would help the brain fog. And then they wrote back last week actually and said, no, you've got a conflict of interest because you run a private clinic. We don't want you to work with us. Any research I do is through my not-for-profit company, which is not a conflict, but anyway, it's very frustrating. So we've got clinics, but none of the clinics are trained in the menopause or perimenopause. They're not routinely asking women. So we've got guidelines actually, which are great. They're being updated all the time. But they don't mention anything about hormones either. They talk about self-management, psychological support, rehabilitation, but nothing about female hormones. So that's quite hard because if actually you tell perimenopausal and menopausal women they need to exercise and think more positively, it can be very difficult if you haven't got the hormones working in your brains. So just to mention the menopause guidance, which have been around now for 6 years actually, and the International Menopause Society guidelines that have been around since 2016, they haven't made as much impact as I hoped they would. They do say that women quite rightly should have individualised care. They should be informed of the benefits and any risks of HRT. And for most women, the benefits of taking HRT outweigh any risks because it's just simply replacing our missing hormones. The risk of breast cancer isn't there for most types of HRT at all, and women are less likely to die from breast cancer taking any type of HRT. And women can take it forever because they're just replacing their hormones the same way as they would take thyroxine. Obviously, lifestyle is important, but it's easier to have a better lifestyle when you've got your hormones back. But I think the last figure may be 14%, but most women aren't taking it. And we actually know that women from low socioeconomic classes are 29% less likely to take HRT. They're more likely to have mental health issues. They're more likely to be obese, more likely to have cardiovascular disease. So again, it's shocking. And actually thinking about prisons earlier was one of the earlier excellent presentations. I've just written a newsletter actually about menopause for women. It goes to every woman who's an inmate in prison. But most of those don't have access to the internet, and they don't have access to a doctor or a menopause specialist, but they have access to a psychologist or psychiatrist who will have no menopause training. So what about HRT? Is it a new opportunity to it? Well, actually, yes, maybe it is. Maybe we could be taking it. I mean, I've got 17,000 patients, and most of those have had COVID, but none of them have been ill. A lot of their partners have been ill, their male partners. It doesn't mean anything, but actually it's something that I don't think we should ignore, and I think it's embarrassing that it is being ignored when every country has been in various lockdown at various times. And actually, I've already said it's safer than a lot of the immune-suppressing drugs that have been used and have been spent a lot of money, actually, on these studies. We also know that women who take HRT not just feel better, but actually we have a lower risk of obesity, heart disease, type 2 diabetes. And that's really important when you look at those people who are more likely to die from COVID. We know older people are more likely to die. We know, sadly, men are more likely to die. But also people who have cardiovascular disease, diabetes, respiratory disease, high blood pressure are more likely to die from COVID. So actually, even if estrogen doesn't affect our immune system the way that we know it does for decades of research, actually, if we have a drug that helps keep us healthier, we all know when we get locked in more and more times, our BMI increases, our risk of other diseases increases, especially if people are drinking more, eating worse. So that's another reason that HRT is actually not all bad and could be very beneficial. So going back to Julie, just to make it real, she decided to go off and get some information herself, actually. So she downloaded our free app. This isn't an advertorial for the app. The app, whatever we do with it, we don't have any external investment with it. I'm very, very keen to make sure that it's free for every woman. So we're trying to get money from corporates, not from women. So we're not going to, but all the functionality is never going to be paid for. So she downloaded a health report, and on the health report, we've got this menopause questionnaire, we've got periods, and what we're using it for is to really help pivot the consultation. So if a woman came to me as a GP with this, I've got the next 9.5 minutes to talk to her about menopause and treatment choices. I don't have to go through to say, have you had hot flashes, have you got joint pains, have you got headaches? It's all there, it's telling me. And so this can really bypass a lot of time and maximise the consultation. So she did this, and she was given HRT actually because The doctor said, well, whether you've got long COVID or raised blood pressure or fibromyalgia or MS or chronic fatigue, it doesn't actually matter because you're perimenopausal, and we know for the majority of women the benefits outweigh the risks. She was given estrogen through the skin as a gel pump because it goes through the skin, there's no risk of clot. And she was given some progesterone because she's still got her womb. Natural progesterone, they're body identical, they're derived from the yam plants, they're cheap as chips, so very effective. She was given some Vagifem Pessaries, which is some local estrogen, so she could sit down a bit more comfortably. And actually then she was given testosterone because as women we produce 3 times more testosterone than estrogen, so that's a very important hormone too. Not licensed actually for women in the UK. You can buy Viagra over the counter, which has more risks, but that's another story. So then she, after 3 months, so she's been suffering for many years, I can honestly say that starting HRT has been life-changing for me. I have also regained my energy levels and joined a gym. I can go through the day without feeling like I'm going to fall over with exhaustion. And this is really important, isn't it? Last line. I'm not saying that I'm going to cure long COVID. I'm not as stupid as that. But I am saying that we should be listened to and maybe thinking more about long COVID. And we're seeing increasingly numbers of women in the clinic who have stories like this. So what to do? Rather than just bang my head against the wall, we need more research. And I just don't know how to get into more research groups. I've even approached someone who works very close to where we're standing now and had a few emails to say, oh, interesting, Louise, I'll read this. And nothing came back. So it's very frustrating. I really feel we need to be listened to as women as well. And I do sometimes think if I was doing this job with a pair of testicles in my pants, I'd probably be listened to a lot better. But also, anyone with long COVID, we should be encouraging them to download the app, asking, do you think it's your hormones, and then addressing that hormone imbalance as well, and considering HRT for those women who may benefit from it. So finally, this is just a plug for my book that's managed to get to a #1 Times bestseller, which I was very proud of, not because I'm an author, but because it's something about women. It was the first time, actually, that a menopause book's been in the top 10 in Sunday Times best-selling list, and it's been there for 4 weeks. So that's something about us being listened to. So I'm just hoping that this momentum can go, but I'm just hoping that the pandemic might be something that will make us think about our hormones as being more important than just to stop hot flushes. So thank you.